And today I'm going to be talking about the new definition of pulmonary hypertension. I have no relevant disclosures. But first, I just wanted to bring up the topic, who decided we needed a new definition of pulmonary hypertension? There's nothing that's essentially different about the pathophysiology of the disease that's present in 2019 as compared to 2018, but now we're saying that the threshold for diagnosis is different. Well, the answer to that question is we had a conference called the World Symposium of Pulmonary Hypertension. These World Symposia on pulmonary hypertension have been held since the 1970s to discuss the status of this disease. And the most recent World Symposium was held in early 2018, and it was discussed in Nice, France. Basically, at this conference, a bunch of experts collaborated and discussed what their thoughts were on pulmonary hypertension, and eventually produced 13 manuscripts which were published in the European Respiratory Journal late 2018, early 2019. And one of the most significant recommendations from these documents were that we should change the hemodynamic definition of pulmonary hypertension. So before we talk about the new definition, I just want to remind you of the old definition. And previously, pulmonary hypertension was diagnosed when patients had a mean pulmonary artery pressure of greater than or equal to 25 millimeters of mercury. Precapillary versus postcapillary pulmonary hypertension was differentiated on the basis of a pulmonary capillary wedge pressure of 15 millimeters of mercury. The new definition changes that. The most significant change in this definition is that a mean pulmonary artery pressure of greater than 20 now defines pulmonary hypertension. And this is true for all subtypes of pulmonary hypertension, not just precapillary pulmonary hypertension. Other things about the definition have not changed, though. The threshold of pulmonary vascular resistance required for the definition of precapillary pulmonary hypertension remains at 3 Woods units. And the pulmonary capillary wedge pressure threshold that differentiates pre versus post-capillary pulmonary hypertension also remains the same at 15 millimeters of mercury. So to understand why we needed a new definition, I think it helps to go back and understand why the thresholds were initially picked as they were. And the threshold of 25 millimeters of mercury was discussed at the original World Symposium on Pulmonary Hypertension back in 1973. And in that time, the situation in the world was different. The main thing going on in the world of pulmonary hypertension was an epidemic of pulmonary arterial hypertension that was induced by anorexigenic drugs, such as the Medrek. And really, the goal of that conference was to identify these patients with a severe phenotype of disease and exclude other patients that may have pulmonary hypertension due to secondary reasons, such as heart disease or lung disease. And the threshold was therefore set somewhat high and somewhat arbitrarily. And again, the goal of setting this threshold was to prevent overdiagnosis and overtreatment. However, there's not really a physiologic basis for the threshold of 25 millimeters of mercury. This is a systematic review that looked at right heart catheterizations that were done in normal people, normal healthy people. And you can see in the mean pulmonary artery pressure in these patients is actually 14 millimeters of mercury with a standard deviation of 3 millimeters of mercury. So if you take the 14 millimeters of mercury, add 2 standard deviations, you get to 20.6 millimeters of mercury. One of the other reasons that a new definition was considered is that there's increasing evidence that patients that have a mean pulmonary artery pressure in the 20 to 24 range have increased risk for worsened outcomes. This was a study looking at all comers in the VA that underwent right heart catheterizations over about a 5-year period. And it found that there was an inflection point in mortality at around 20 millimeters of mercury. Essentially, these patients, regardless of the cause of the pulmonary hypertension, had worse outcomes if their mean pulmonary artery pressure was greater than or equal to 20. Similar results were found in a different study that was based in Austria. Again, this is looking at all comers who underwent right heart catheterization. Again, showing that this borderline kind of range of 20 to 24 millimeters of mercury was associated with worse outcomes. And then kind of the third reason for considering a new definition is that lowering the threshold might identify patients with early vascular disease. And this is particularly important in a couple subsets of patients. In one subset is scleroderma. Patients with scleroderma are at increased risk for pulmonary arterial hypertension. This is a study that screened patients with scleroderma and features that were concerning for pulmonary hypertension with right heart catheterizations. So everybody got a first right heart cath, and then a subset of patients got a second right heart cath due to symptoms that they developed over the course of a few years. And out of these patients, of the patients who initially had a pressure in the 20 to 24 range, approximately 20% of them developed a pulmonary artery pressure of greater than 25 within 3 years and progressed to the old definition of pulmonary hypertension. Only about 5% that had a pressure less than 20 progressed. And then the other subgroup where it's thought that having early vascular changes may put these patients at increased risk is within the CTEPH and CTED population. This study looked at 42 patients that had a mean pulmonary artery pressure of less than 25 millimeters of mercury and actually underwent pulmonary endarterectomy. And these patients who underwent endarterectomy without having this mean pulmonary artery pressure of greater than 25 did have some improvements in their quality of life, in their 6-minute walk distance, and in their hemodynamics. And these patients had real disease. They had, very significant clot burden that was removed with the pulmonary endarterectomy. So some of the pros in the new definition, it definitely is arguable that it reflects normal pathophysiology better. It may identify patients who are at increased risk for worsened outcomes, regardless of the cause of the pulmonary hypertension. It may lead to earlier identification and treatment of patients within specific subgroups. And it can also kind of guide our future clinical trials in terms of who to enroll. However, there are some downsides to the new definition. One of the negatives of the definition is that all of our old clinical trials in pulmonary hypertension did not use this threshold. They all use the threshold of 25 millimeters of mercury. So we're kind of left with this question, what do we do with these patients who have a mean pulmonary pressure between 20 to 24? We don't really have any evidence that any of these therapies that we use for pulmonary arterial hypertension are useful. It also, I think, gives these patients kind of a lot of psychological burden. I mean, you're diagnosed with a disease, but yet we can't offer you treatments. We just kind of have to wait until it gets worse, which I think can be nerve-wracking for patients. Other aspects of the hemodynamic definition have not changed, including the pulmonary vascular resistance and pulmonary capillary wedge pressure. And I'll argue that this really kind of limits how many patients will be reclassified into the new definition. And I think to understand that, it helps to go back and look at the hemodynamics. When we do a right heart cath, we look at the mean pulmonary artery pressure, the pulmonary capillary wedge pressure, and then calculate a pulmonary vascular resistance based on these two parameters as well as cardiac output. And so in this definition here, if we see that the mean pulmonary artery pressure is lowered to the 20 millimeters of mercury, yet the PVR criteria remains at 3 Woods units, essentially in order to be reclassified as having the pulmonary hypertension, you need to have a relatively low wedge pressure and a relatively low cardiac output. And this just may not be that common. This study was looking at 2 centers in Europe that evaluated all comers who underwent right heart catheterization. And these are all the patients that were evaluated. These were the patients that had a pressure between 21 to 24 millimeters of mercury. Then after you exclude patients that had an elevated wedge pressure, you have even fewer patients. And then if you further refine the definition and only look at those patients with a pulmonary vascular resistance of greater than 3, you have even fewer patients. So it's only 1 to 2% out of this cohort. This was even seen in scleroderma, which is one of the populations that the new definition was kind of developed to try to address. These patients, again, were patients with scleroderma who are screened for pulmonary arterial hypertension based on right heart catheterization. And this is how they're classified by the old definition. When they're reclassified by the new definition, some changes did occur. There were 7 patients who were reclassified as having pulmonary hypertension, but only one of those patients had pulmonary arterial hypertension. So that's 1 patient out of 268, which is not a lot. There are a lot of patients, however, in this kind of in-between group that had a mean pulmonary pressure greater than 20, that had a wedge less than 15, and a PVR that was in the 2 to 3 range. So, just going back in some of the cons of the new definition, really limited numbers of patients might be reclassified at least as pulmonary arterial hypertension based on this definition. And kind of looking forward, you have to wonder if other aspects of the hemodynamic definition will have to be modified in future world symposia. So these are my take-home points. Again, the threshold for the definition of pulmonary hypertension has been reduced to 20 millimeters of mercury, but other parameters have not changed, including the pulmonary vascular resistance. This new definition better reflects physiology and may identify more patients that are at risk for severe disease. But we don't really know what to do with patients that have the mean pressure in the 20 to 24 range. And we may not really identify that many more patients that have pulmonary arterial hypertension based on this definition. Thank you. Thank you.
So that was a wonderful presentation. Thank you so much. I actually was wondering what you thought from based on your reading and your perspective. Do you feel would be best? Should we be more actively following these patients? Should we be recathing these patients in this 20 to 25 range? What do you think the future looks like for studies for those patients?
Well, I think, I hope going forward that, I've already seen that some of the studies have changed. There are new studies coming out have changed the inclusion criteria to meet this new definition. So I think going forward, clinical trials should enroll patients based on the new definition. In regards to what to do right now, I know I have one patient that fits this criteria, the 1 to 2% or whatever that we saw met this criteria, and she's a scleroderma patient. So in her, we kind of had a discussion about risks and benefits, and she also had some concomitant lung disease and had a good functional status. So in her, we elected not to do any kind of vasodilator therapy in favor of close follow-up. But I think, you could argue that other patients, especially if they have something like scleroderma or heritable PH, and you kind of expect them to worsen, that is probably not unreasonable to at least start a single agent.
Very good. Thank you.
Thank you.
Anybody else have any questions?
I know the research for PH is highly dependent on sponsorship.
Yeah.
The article which changed the criteria, none of the authors has all of the authors are sponsored. What do you estimate would be the financial benefit to changing this using all comers? Is there a guesstimate you can say in terms of how many more patients get reclassified on a global basis?
Well, in terms of the patients that get reclassified as pulmonary arterial hypertension, I think the numbers really aren't that large. It's hard to estimate exactly how many on a global scale. I think it really includes a lot more of the patients that have concomitant pulmonary cardiac disease, because a lot of those patients fall into this range as well. So I think it's good for those patients because it kind of increases their identification and kind of alerts their providers to the fact that they have increased risk for worsened outcomes in general.
So in your practice, when you say that you would have to closely monitor, for example, your scleroderma patient, do you then do like 6-month echoes and walk tests in your clinic for these patients when you monitor them?
Yeah, for her we did, I think at 3 months even, we did a repeat 6-minute walk and echocardiogram as well as an NT-proBNP level.
Gotcha.
We might space that out going forward, but given the research in scleroderma, she's still at risk for further progression.
Sorry. If you're an old physiologist like me, you would say it all depends on pulmonary vascular resistance. That cardiac output is such a... But then, we do... I don't know how many people here do right heart caths. I kind of got suckered into it, 10 years worth of doing it. And we run the cardiac outputs like the Olympics. Shoot 5, throw out the low, the high, take the mean. And it always leaves you scratching your head. And I think maybe the answer is Bayesian. Pre-test probability, so you get these dialysis patients and their values are kind of this way, but then you look at their cardiac output, and it's 8.5 liters. You're kind of like, go back to dialysis. But the scleroderma people always made us nervous. Why? Because their pre-test probability of getting PH. And so I think the answer, which I think you were bringing up, is those are the people maybe you bring them back for their 6-minute walks a lot more often. And kind of, get them to say, hey, if you start feeling bad, give me a call ahead of time. So, yeah, I understand lowering a little bit, but it's all three, right? PA pressure has to be high, wedge has to be low, and the PVR has to be over 3. The hard part is getting those cardiac outputs. I don't know what the crowd's experience is, but I have a natural distrust of it, even though I do it.
Yeah, and I think it helps sometimes to, corroborate the thermodilution cardiac output in the FIC just to make sure there's agreement. Although overall, I'd say that I trust the thermodilution a little bit more than the FIC. But yeah, that's the other kind of con of the new definition. It really relies on having an accurate cardiac output as well as an accurate pulmonary capillary wedge pressure measurement, which is something that's really variable in some people. You really need to make sure you have a good tracing at an expiration and have a good value there.